Hello, everyone. Thank you so much for being here today. I want to welcome you guys to this panel discussion that we're talking about, and we're going to be talking about the implementation of zero trust architectures in the healthcare industry. I'm Dr. Shaila Rana. I am the co-founder of the ACT Research Institute, and I am also a faculty member at Purdue Global. I wanted to give a chance to introduce our panel. So Rob, did you want to start with introducing yourself?
Yes, I'm Professor Kranenburg, and I've been working on, but it's now called Internet of Things for about 20 years, and mainly also in European projects, and always very much in the intersection of technology and society. And at the moment, I'm working on a large sort of a proposal on security of AI. In that case, I think what we see is that security and cybersecurity is rising very much on high on the list of what people need to do at this very moment. So yes, based in Ghent in Belgium.
Thank you so much for your introduction. And Jim, did you want to take a moment to introduce yourself?
Sure, thank you very much. Yeah, Jim St. Clair. I'm a consultant advisor with a number of companies, but have previously served with the Linux Foundation, Providence Health, and previously with some other government contractors. In my work today, I've been involved in identity, patient identity, and patient verification for several years, as well as working with federal working groups around the federal structure for implementing zero trust architecture, and have recently been participating in a federal identity management working group where we're looking at the use of identity credentials and zero trust architecture for both improving identity management and identity security, as well as zero trust security frameworks. And through that, organizations such as the Department of Health and Human Services or others are looking at the adoption of zero trust architecture, which has implications for the healthcare industry.
Awesome. Thank you so much. So as we delve into this topic, it's important to recognize the criticality of ZTA as a component of cybersecurity. So in this era where cyber threats are evolving and becoming more sophisticated, it is imperative that we take these proactive measures to safeguard our networks, our devices, our data. And the healthcare industry in particular has increasingly been targeted by nefarious actors due to the nature of patient health information. So that's the importance of what we're doing here today. And our learning objectives for today's discussion are to identify how ZTA can help protect the healthcare industry and describe the challenges and remediations associated with this. We'll also analyze the vulnerabilities in healthcare information systems caused by the rise of telemedicine, remote work, and online communications. And then we'll evaluate how the implementation of a zero trust approach can reduce the risk and impact of security incidents. So I'm really confident that our panelists today will provide those valuable insights and engage in an important discussion. So with that being said, thank you all for being here today. And I want to start off with our first question, which is, what are the vulnerabilities in healthcare information systems? And how has that been caused by the rise of telemedicine, remote work, and online communications?
Rana, who would you like to take that first?
Oh, sorry. Jim, did you want to start off?
Be happy to. Yeah, that's a great question to provide some background. Both the Health ISAC Information Sharing and Analysis Center and the Health Sector Coordinating Committee, which is a industry sector focus on cybersecurity with the Department of Homeland Security, CISA, HHS, and others, has been pointing out both numerous instances where ransomware, denial of service attacks are occurring both at large hospitals and small. And in many cases, a foundation to that is simply trusting who you're communicating with and where the information is coming from. We've also seen various supply chain attack problems that have occurred because a trusted supplier or a trusted supply chain component had credentials that were trusted and that allowed them access to a system. And when they were compromised, there was no mechanism for being able to repudiate that trust and being able to improve security. Many people are probably familiar with the SolarWinds incident, which served as a basis for a lot of the government, U.S. federal government looking at zero trust architecture adoption. And that essentially occurred because the SolarWinds management system had trusted credentials that allowed the system to have access. And when those credentials were compromised, there was no way to challenge and reauthorize those credentials and stem the implications for violating the system. As a result, zero trust architecture came about, and specific to the healthcare sector, the idea that, of course, there are various sources of information, various systems, various parts of the supply chain where you don't want to grant permission and access on a continuous basis without some means of reauthorizing and ensure those credentials are still valid and ensure that the network isn't being compromised. And so in healthcare, zero trust architecture has lots of implications, I think, both implications for security as laid out in the NIST 800-207 series, and how to properly construct and manage your risk with zero trust architecture. And then the idea that identity sits as one of the pillars for zero trust architecture. Identity can be both the identity of your system users, your employees, your administrators, plus the identity of the patients that are seeking access to their information that they're authorized to see. So zero trust has several layers to consider for improving both the security of a hospital or a healthcare system, as well as the security of the patient's data.
Excellent. I totally agree. Rob, was there anything that you wanted to add?
Well, I think especially on the part of the supply chain and sort of is that indeed sort of no one is sort of an island and nobody's sort of out there on their own, as everything is connected and hospitals are connected and they need to be connected. And so it's always a kind of a trade-off in the supply chain on about security, as much as possible security, and sharing, sort of, because you also need to share data, you need to share patient files, you need to share kind of processes, and so it's always about this trade-off, and that's I think the fine line, or finding the fine line, and building the fine-tuning the balance between that, I think is one of the things that are key. Yes.
Thank you so much. I agree. So, Rob, I wanted to follow up and ask you, what are the key components of a zero trust approach, and why do you think these are key components in the overall approach to cybersecurity? And I believe you had a presentation that you wanted to share with us today.
Yes, and there I'd like to talk about a specific instantiation of zero knowledge proof, and that's disposable identities. And that's a term that we found about a few years ago, and it had to do with what we're seeing now all over, and especially with AI, is that objects and things are broken down into all kinds of properties, and with these properties, new elements can be composed. And so we're going to see a world not so much of subjects or objects or persons, but all kinds of properties of these persons and objects and things. And there we got down to this notion of disposable identities, where we have a Telegram group that we can share. So basically, going down to identities, asking these questions: who owns your identity? Is identity individual, group, human, or a thing? Is identity the same in the digital as in the physical? Has your identity ever been stolen? What does that mean? And do you have more than one identity? And there we see that something is going wrong or has gone wrong. So we have 1 in 5 Europeans have experienced identity theft, fraud in the last 2 years. 22% of breaches involved phishing. Sort of we can go on and on, and sort of we can have these ideas of most people having 70 to 80 passwords. Of course, things can go wrong, sort of in that notion, in that instance. So the key is, like, with the balance between and the trade-off between sharing and isolation in the supply chain is privacy versus trust. So with privacy, we think about private things, protection, being hidden, separation, walled off, the right to determine what is hidden and what, how, and when to disclose to the public. And on the other side, we have this notion of trust, a social contract based on trust between social sharers, individuals, intermediaries, and groups of people online and offline. And so basically now we're at this kind of crossroads where we have kind of a current identity model where people have passwords and signing in and using intermediaries to build trust layers, where we aim to go to self-sovereign identity, where basically you hold a set of identifiers and then you basically allow certain services to engage with your identifiers. But we want to go a step further, and that is where we want to think about disposable identities. And there you have to think about a world in which basically you can have a separate contract with any kind of service. So from your self-sovereign identity, you can make disposable identities, which is identities which do not have to be correlated with your with your SSI, with your self-sovereign identity. And that could be either fully anonymous, or they could be semi-anonymous. But the idea and the key is here that in this world in which everything is connected to everything else, you need to be able to hold the keys to your own identity and expose them only when you want them, when you want to do so. So, for example, if I were to engage in if I live somewhere and I want to engage in a contract with energy, with an energy provider, all I have to send is one credential that I can pay, and that's basically all that anyone needs to know. So that's kind of the kind of world that we want to go to, and this is the work of a foundation called Twins, and they're located in Belgium. And they're building a disposable and identities toolkit, an SDK, and that SDK can be used for building all kinds of services like that on this. So that's basically what I would like to what I'd like to show.
Okay, did you want to share the screen with your presentation so that we can see it, or?
Oh, you didn't see it.
No, the screen's not shared right now.
Oh.
In the meantime, Jim, did you have anything to add about what are the key components of a zero trust approach?
Yeah, absolutely. Well, I see that Rob's getting the slides up, which is wonderful. I would just add real quickly and turn it back over to him that I'm thrilled that he touched upon the topics of decentralized identity and disposable identity as really being important pillars for zero trust. And it's my personal opinion that part of the challenges with the implementation of zero trust is that it's not culturally recognized that zero trust means, as it says, I don't trust you and you don't trust me, meaning that both parties have to have a means to be able to verify their identity provide a zero knowledge proof, as Rob was indicating, and enforce that both the party that you're transacting with, or both parties that are transacting together, trust each other based on a trust framework. With that, I'll turn it back over to Rob, because it looks like he's got some great graphics on that right now.
Yes, I think thanks, but I think that's exactly what the key was. We're moving from this centralized version to this decentralized version. And one of the pillars of this decentralized version is this self-sovereign identity, where people hold the keys to basically allowing services to deal with their data and with their identity. But we think that in this particular world in which we're going, and which we basically are already in, we need another step, which is this notion of this disposable identity, the idea that you can create identities for specific services, and then you, on the basis of what you said what you're saying in the contract and how you specify it, these kinds of identities can be removed after half a year. They can be only really vitally used if the specific actions are being made. And this sounds quite complex, and especially it is quite complex in the real world. And like you just said, we have these misunderstandings in the real world. Saying something like, "I don't trust you, you don't trust me, let's go and do something," sort of doesn't really work. It's like it's kind of the opposite of how we operate in the real world, where we are used to operate on trust, where we basically say, I think I trust you because of this and this and this. You trust me because of this and this and this. Then we can go into a business, we can go into a relationship, we can go into a contract.
And Rob, could I say real quick, if I can interject, because I love what you're saying. I always use the Uber example. Physically, I get into a car with somebody I don't know, which I'm pretty sure my mom said I was never supposed to do. Meanwhile, the driver has some stranger in their back seat. But the entire successful business model is built around a trust framework that I don't trust the driver necessarily, or I trust the driver and the driver trusts me, because we have a framework that we've agreed upon for how we're going to work to do this transaction. And that's a basic trust framework anyone can understand that I think Rob's alluding to now. Thank you, sir.
Yeah. No, I think that's a perfect example, and that also shows that how easy it is that we operate these actions on a day-to-day basis. Yes, if we start to actually break them down into what's happening, things become quite complex, and they also become counterintuitive. And that's, I think, one of the things that this zero trust architecture is kind of from a person point of view. Seems counterintuitive, whereas we're dealing with machines, and as long as we're dealing with machines, and especially with machines that are now creating more traffic, or basically than any kind of human operators at this moment on the internet, or we need to basically have architectures that are based and thinking like machines are doing, and that's the good thing and the beauty of this zero knowledge proof architecture.
So to build on that great information that you both have shared of the importance of having a zero trust approach, why is the healthcare industry frequently targeted by nefarious actors? What makes it so prime for malicious actors to want to target and attack information?
I'll be happy to take that for a second, Rana, and I'll circle it back to where Rob was in your initial question about telehealth and telemedicine. One of the fundamental things about healthcare security is oftentimes just a matter of resources. A significant portion of healthcare delivery in the U.S. happens in rural environments, as you would expect. Rural hospitals, rural facilities, and rural CEOs really don't have the infrastructure. And of course, their focus is making sure that they have enough doctors and nurses and clinicians to deliver services. That has to be an ancillary consideration beyond their ability to have a cardiologist, or to be able to have to take x-rays, to have cybersecurity professionals. And yet, as technology expands and even rural facilities are getting more involved in telehealth and telemedicine through things like broadband grants and other grants from HHS, state level efforts. You're both increasing that computing capability, you're increasing their online footprint, their online vulnerability, and having to deal with more transactions in the digital world than they were previously, but at the same time, not necessarily having all of these components of zero trust to be able to support and reinforce what they're doing. At the same time, the individual who is, say, in a telehealth encounter wants to make sure that when they click on that link to join a telehealth session, that there hasn't been some sort of man-in-the-middle attack and some sort of hijack, and that their health information is going to be stolen, meaning they have to be able to provide credentials that say, I am who I say I am when you're connecting into a telehealth session. And the patient also wants to know that they can trust the source that they're connecting to for telehealth. And this is a paradigm of challenges for especially newer and smaller healthcare organizations to be able to have that sort of digital trust in the model that Rob was talking about.
Right. Rob, was there anything you wanted to add about what makes
I
the
think
healthcare
so.
industry frequently targeted? Yes.
Yeah. Well, I think so. On the one hand, basically what we see is that all these similar types of institutions are being like city halls, and they're all being targeted. And sort of, but the hospital, I mean, it has so much private information and it has so much sensitive information that sort of hacking that, secure, sort of closing that down, and then demanding for ransom is relatively at some point people are going to either pay, sort of. So it's but I think sort of what we see happening on especially in rural areas is that care is moving closer to persons. It's moving closer to people, and the phone is becoming a very important sort of mediator for care, and of course not for the care that when you when you have an attack and you need to go to a hospital, but basically, and this is also what we will see happening basically everywhere, is that care will move more to persons, and so that this kind of these kinds of attacks can also become more closer to a personal level and more closer to on the phone, which is another argument for this model of self-sovereign identity, which of course will mean a tremendous education and re-education into people in digital habits and assets. But I think if we see, especially with the younger people being so literate in some aspects on sort of that may happen. But I saw you nodding sort of that on this issue.
Yes, you're exactly right. So to extend that, how does implementing a zero trust approach reduce the impact of security incidents and that disproportionate burden of having to protect patient and health information especially for rural hospitals, rural CEOs? Jim, did you want to take that?
Yes, certainly. I think that the historical trend has been, quite frankly, spending a lot of money for a security architecture or security infrastructure and parts and pieces and software that you need just to be able to assure yourself that some part of your system is not being compromised and that something is being subjected to a compromise and that your data is being stolen. Moving more and more to zero trust allows you to establish, first of all, what we've talked about here with that trust framework and a system of credentials or identities that have to be validated. So the very first point before you connect with somebody and start exchanging information is saying, do you have a reason to connect with me? Do we have a reason to conduct a transaction? And Rob is just highlighting that in his presentation. And the ability to provide valid credentials, valid information to affirm that, yes, I can trust you. And at the same time, you can trust me, because we both cryptographically or digitally agree on a framework of trust to do something. That represents a lot of technology that is already out there that we now need to make a move to in order to make it much easier to conduct virtual care and telehealth from an infrastructure standpoint. And just to kind of highlight what Rob was showing, like in that disposable identities, you saw that ring of all the various applications and accounts that people need to maintain. Being able to have those in the context of what is higher risk than something else, what's lower risk, how do I need to apply additional safeguards? That works both for the healthcare system as well as for a patient or someone connecting into that system to be able to take that determination. I believe it's CISA, the Cyber Infrastructure Security Agency, has a new digital identity risk assessment framework that asks some of these questions to be able to consider, as you construct identities and credentials, what is the risk associated with how you're using that identity or what that identity is being used to access. And I think that's a direction to be able to go as well for, as Rob pointed out, highly sensitive systems in healthcare where there is protected health information, less sensitive systems that are administrative, and making sure those systems aren't all just connected together so that there's no trust boundary between them.
Thank you for sharing that resource. That's an excellent resource. And Rob, was there anything that you wanted to add?
Yes, I actually wanted to show something because I think it's enlightening. So you see the screen, I think.
Yes, we can see it.
Yeah. So we have, and this is going back to what Jim was saying earlier. So this identity, we have disposability, which is time, purpose, and context. So you can say this identity is lasting for this amount of time. It's purely usable for this purpose or context. Verifiability, privacy, transparency, and trustworthiness, which is kind of the highest level of what you can get. And so the framework, and this is also what Jim was explaining with credentials, is that basically what Twins Foundation has built is this disposable identities app, which gives proof. The proof is verified identity data and credentials. And then it gives transparency. It has this data sharing manager, manages terms of access to user identity and data, when, where, for how long, or to whom. And especially, I would say, in a health context, these kinds of sets of data are becoming very important. Also, in terms of mental health and mental health issues, we see that are on the rise very much. We see in Europe, we see a tremendous rise in burnouts, in longer and shorter periods of depression, and data sort of dealing with these types of illnesses and states are very, very sensitive. And so allowing people to set a time and a purpose and whom, sort of to set certain types of data to certain types of contexts is really, I would say, very much how people are using apps today. Young people are using apps today. They assign this identity to, basically they say this in that app, they say this in that app, and sort of and then it goes into security, which is personal data storage and access. Sort of just to highlight that Twins is supporting a specific zero proof, and that is a Zenroom cryptographic engine, contains the capabilities for creating Z proofs, which basically to prove that some or all parts of a verifiable credentials are true without revealing the personal information contained in such a credential. And that's seen as this enhanced data protection mechanism. So so these zero knowledge proofs are worked inside of this, are working inside of these such an application. And I think with the rise of these notions of self-sovereign identity, so basic architectures like this will be seen very as something very logical. So once the actual everyday actions of people start to coincide with the ways of the working of the machines. So when the notion of trust is actually seen as relevant as the notion of zero knowledge trust, I think things will become I think we'll see more of these types of applications.
Yeah, and I'm very hopeful for that future as well. But I think it's also important that we address what the specific challenges would be with implementing a zero trust architecture within the healthcare industry specifically. Rob, did you want to expand upon that?
I think it's basically is a mindset issue in terms of security and in terms of security architectures. There should not be a real issue. So it really is about understanding how the data and information flows in the environment itself are being controlled by whom, if they're being controlled more by patients or more by the institution.
Jim, did you want to take that question as well about this?
Yeah, absolutely. And I thought Rob laid a lot of great groundwork for discussing this topic. I have found, regardless of the organization, the governments, the country, there's a lot of global cultural challenges here. And in that slide, Rob made reference to Sovereign, which I've been a member of, My Data Global, which I've been involved with before. And these are a lot of like-minded people on a global basis that are very interested in these principles of what we call self-sovereign identity, decentralized identity, person-centric data, et cetera. And for industries and governments as a whole, as well as for healthcare in particular, it is a huge cultural mindset issue. And if you get into healthcare, even within those communities, I myself have tried to argue, okay, what are my rights to self-sovereign identity when I'm unconscious on the hospital bed after being brought in by an ambulance? Somebody I haven't talked to or authorized needs to know everything about me as quickly as possible. So there are operational considerations as well, but I think because of that and because of the trusted nature that clinicians have on a global basis, whether it's Germany, the UK, US, whatever, there's always been a tendency to say, well, I'll give my healthcare information to my trusted provider because they need to know about me from a medical standpoint. But as that has changed more and more to a digital world, as there's commercial health services that we go to, as there's apps that we use that have health information in them, that composite picture of who I am from a healthcare standpoint and my healthcare data is actually distributed over a wide variety. And I think organizations like My Data Global and others are starting to say, why don't I have my own personal data repository? Why don't I have my own personal data store? And in Rob's case, he's probably seen this with the European Health Data Spaces, which is the new initiative to help give citizens more control over their data, not just from a privacy preserving perspective, but also just to say, rather than me continuously giving my health information out in parts and pieces to a dozen different sources, why can't I know everything that there is to know about me for my healthcare data? And then from there, empower how I share that data and set up the trust framework for that data sharing, whether it's back to my doctor or hospital or as part of an application I use. And I think this comes back to Rob's comments about a disposable identity. The identity that I want to have with my Fitbit would be very different than perhaps what I have with my cardiologist. There's a lot I want my cardiologist to know about me that my Fitbit has no reason to know. But that doesn't mean that in a trust framework between the three, that the Fitbit isn't providing information that both I and the cardiologist benefit from. So how do I set up that trust framework, that disposable identity, so I know all about me and my information, and my physician knows certain other additional details, and then maybe the consumer applications and other applications that I'm using to support that details have a different sort of trust relationship as well.
Thank you so much. So just to end off here, I wanted to talk about a specific example of a successful implementation of a zero trust approach in a healthcare organization. Jim, have you had experience with this before?
You know, I will say that I have not, though several colleagues of mine within the community are doing more and more with zero trust. There are several large-scale frameworks that are being developed for zero trust in healthcare, being sponsored or involved with Health and Human Services. I'd also say that there's quite a bit of work being done in international standards, such as the HL7 Patient Identity Implementation Guide, to be able to align how healthcare data is stored and used to be able to incorporate patient identity, patient verification, which is very important groundwork for patient identity. What I have found, what I'm still involved with, similar to what Rob is saying, is that you create the architecture for zero trust and how to use those verifiable credentials and digital information. And then I have to be able to associate that with where my health information resides digitally. So it's not only I am who I say I am, but I can lay a cryptographic claim to say that's my data over there, or this is the most recent document about me, and connecting that together in an architecture, especially if I have a personal data store where I need to be able to say, I have the latest version of, you know, these test results about me, and they came from this trusted source, and I'm now sharing them with you and only you.
Thank you so much. And Rob, was there anything that you wanted to add? Have you seen a successful implementation?
You're on mute, Rob.
I think you're on mute. Yeah.
Sorry, sorry for that. No, so the work that the Twins Foundation at the moment is ongoing. So the SDK is there, the work is there. They're having a pilot at this moment, not in health, but in food. And what we find in health is that there is, well, it's a very difficult environment to work in, or to do innovation in. There's an enormous amount of legacy. It's all the work in care is also tremendously vital and ongoing. It's very difficult to sort of to do a demo or a prototype, or what to say, or to sort of hold operation for a while and implement something new. So everything has to be implemented basically. Sort of, it's very difficult and very complex. So I think at sort of we're basically trying to get in there, but it's difficult.
Thank you so much. So I want to thank you all for your time today. I really appreciate those excellent insights that you all have provided for all of us, including what a successful implementation would need, the challenges associated, and you discussed the remediations for that as well. So I'm hopeful for a more secure future, and thank you all for your time today.
Thank you, Rana.
Thank you very much.